Good morning, good afternoon, good evening, because you're all from different parts of the world. So we have here a special cyber site webinar, this time on manual small incision cataract surgery. And we have three phenomenal speakers from the Indian subcontinent from three different countries, each one of them with a different perspective and experience in doing manual small incision cataract surgery. So without much ado, let's start with the webinar. So I'm Parikshit Gogate. I'm an ophthalmologist based in Pune, India. And I've been doing manual small incision surgery for the past 25 years. I became a phaco surgeon first and then a manual SICS surgeon. And there are many places where even when we have phaco available, manual SICS can still be the surgery of choice. In fact, Orbis International had commissioned this manual for manual SICS way back in 2005, almost 20 years ago, when Dr. Eugene Havelston and Dr. David Hunter Cheve had asked Professor Ravi Thomas and Dr. Prasad Garg to compile this. Professor Thomas was at that time the director of the LV Prasad Eye Institute, which now Dr. Prasad Garg is. He is the director and the chairman. And we are having this webinar in the memory of Professor Ravi Thomas. Professor Thomas is a teacher par excellence. He was born in Raipur in a forested tribal area of central India. And perhaps I think his upbringing in that very poor remote region with parents who had missionary orientation put him on the path to do what he did in life. He was the head of ophthalmology at Christian Medical College, Vellore, then the director of LV Prasad Eye Institute, Hyderabad, and finally as a professor of glaucoma and ophthalmic epidemiology at Queensland Eye Institute, Sydney. To his students, he always taught that the eye care that has to be delivered has to be of excellent quality. It has to be equal to everybody. And we have to have a lot of compassion, good feeling for our patients, because that is what they have come to us, not just to get their eyes fixed, but as human beings who need care. And in fact, the three speakers that we have today are also from three institutes who each one of them follow this quality, equity, and compassion that Professor Ravi Thomas so passionately taught in his life. This is the webinar. We have Dr. Nitin Tulsyan, Dr. Haripriya Aravind, and Dr. Sarwar Alam. And they will all be showing you various videos of manual small incision cataract surgery. You can ask questions on the sideboard and they will be more than happy to answer you. So first we have Dr. Nitin Tulsyan, who is from RM Kedia Hospital in Birganj. This is a Nepal Netra Jyoti Sangh affiliate, and it does thousands of cataract surgeries for Nepalese and Indian patients. And he's the medical director there, also a very well-known pediatric ophthalmologist with interest in research and teaching. Dr. Haripriya Aravind is, of course, a star in Indian and global ophthalmology. She has had so many sessions in AIOS, in the American Academy, with numerous publications and awards to her credit. She heads the Aravind Eye Hospital in Chennai. Aravind is synonymous with quality, synonymous with compassion, and it is perhaps the largest practice in the world. They do more than 300,000 surgeries every year. Correct me if I'm wrong, Dr. Haripriya, and 60-70% of them is done completely free of cost. And they are, in fact, we can say the womb where manual small incision cataract surgery really flowered, and perhaps the first institution globally to shift completely to that for all its non-paying patients and its paying patients too. And finally, we have Dr. Sarwar Alam, who's an ophthalmologist and head of the education department at the Isfani Islamia Eye Institute in Dhaka. The Islamia Institute has been called as the Aravind of Bangladesh. I mean, they also do a phenomenal amount of work, a lot of work, completely again free of cost or at very less cost, and is a very famous training center in its own right. So I think we will now start off. I'll hand this over to Dr. Nitin Tulsyan, a friend and a colleague. And over to you, Dr. Nitin. Please go ahead.
Yeah, thank you, Dr. Gogate. So I'll be talking to you regarding tactics and complication management and of corneal tunnel construction. Myself, Dr. Nitin Tulsyan, Medical Director and Vitreoretinal and Cataract Surgeon at RMKDI Hospital, Birganj, Nepal. So to begin with this surgery, we first perform a conjunctival peritomy before construction of a tunnel. And in this picture, we can see there is a suture given here. That is superior rectus bridal suture. These days, we rarely use these sutures. Most of the time, we don't use it now. And going with the conjunctival peritomy, we pick the conjunctiva and the tendons with the forceps. And then we give a nick with the scissors and then straightly go in and cut the conjunctiva at the limbus. So what is the benefit of doing conjunctival peritomy is to expose the blue limbal zone without overhanging conjunctiva. And we excise the tenons because presence of tenons may cause irregular incision, septation within the tunnel, and poor depth perception. So few surgeons prefer to use wet field cautery, but generally we don't use wet field cautery. But the advantages are it allows proper visualization of the instrument, it prevents or minimizes bleed into the anterior chamber, and wet field bipolar cautery allows lateral distribution of heat over the scleral surface. So the points to consider in this is point cautery should be applied to scleral bleeders only. Cautery of limbal blue zone bleeders has to be avoided. And cauterization without proper tenons fascia removal may cause inefficient cauterization. And cauterized tenons will be difficult to separate from the sclera. Once scleral incision and tunneling is done, cautery should not be applied. It may cause fish mouthing and subsequent wound leak. So the construction of triplanar sclerocorneal tunnel, it was first introduced by Paul Ernest, and it's also known as corneal bulb incision. It has three components, that is external scleral incision, sclerocorneal tunnel, and internal corneal incision. This is the picture which clearly depicts what are the components. In this, we can see an incision. This is the external incision, then the sclerocorneal tunnel, and then the internal incision. And there is the flap of conjunctiva deflected. And in these pictures, we can see how first we give a scleral incision perpendicular to the surface. In this, there are two methods. One is tangential slope or perpendicular. In this, what we see is when we give a perpendicular incision, the wound is nicely opposed. Whereas when we give slope or tangential, then there is some gaping in the wound. And the different types of incision that we can use is a smile incision, straight incision, and frown incision, chevron incision, and inverted batwing incision. It depends what surgeon basically prefers because it's all surgeon's choice. But what we would say is, I'll tell you later what is the best incision to be given. So in this, the point to be kept in mind is astigmatic neutral funnel. So surgically induced astigmatism is directly proportional to the cube of the length of the incision. And it's longer the length of the incision, the larger will be the surgically induced astigmatism. And surgically induced astigmatism is inversely related to the distance from the limbus. So more we go away from the limbus, less will be the astigmatism. But it doesn't mean that we go too much away from the limbus because the normal distance from the limbus should be 1.5 to 2 mm. So if you go beyond that, then there might be premature entry and there might be a ciliary prolapse. So location is usually the convex part of the frown incision is along the posterior limbal line. So we can see here it's mentioned frown incision. So the best incision will be frown. This corresponds to about 1.5 mm from conjunctival insertion. So the incision depth, the ideal incision depth should be half to 3/4 of the scleral thickness. It should be uniformly deep along its length. And if it's less than 50%, then there might be chances of thin roof or buttonholing during tunneling. So the optimal thickness is 50 to 75%. Now, if it's more than 75%, then there will be deeper plane, thin floor, and there are chances of premature entry. And if we go 100%, then there will be scleral disinsertion leading to ciliary prolapse. So how we construct a tunnel is, we construct it using crescent blade, gently wiggling and sweeping movements. Uniform thickness scleral tunnel extending up to 2 to 3 mm into the clear cornea, and then forward surface of the blade should just be visible. Tunneling forward, raise the tip and depress the heel of the blade. This is the way how we proceed forward. Raise the tip and depress the heel of the blade and move forward. Sideways sweeping movement. So this is the initiating. In this picture, we can see the initiation point and then the sclerocorneal tunnel. And this is the sideways movement, that we sweeping and wriggling movement. And in this, if you go superficial, then this might lead to buttonholing. And if you go deep, this will cause premature entry. So how we enter into the anterior chamber? One is we can move a swinging movement of the keratome, or we can just go straight in with sideways movement, which I'll show you in my videos. How do I enter the anterior chamber? And in this, once we enter the anterior chamber, and then we go sideways cutting. In this picture, we can see. So the incision will be frown externally and smile internally. So internal corneal incision is constructed using keratome. Heel of the keratome is raised to create a dimple on the corneal surface. And then the keratome advanced anteriorly in same plane until anterior chamber is entered. And extension of the incision done in same plane as a straight line. There is a diagrammatic representation where the incision should be given, how long the incision should be, and how much to go into the clear cornea. So the advantages of tunnel are, intraoperatively, in case if there is expulsive choroidal hemorrhage, it can be managed by simply removing the instruments because the wound will close. Respiratory or cardiac incidents can be dealt by removing the instruments during resuscitation period. Postoperatively, there is lower chances of hyphema, no suture-induced foreign body sensation, decreased iris prolapse, avoidance of hypotony, and strong wound integrity. So this is a video of mine saying, in this we'll show how a peritomy is performed and tunnel is made. See, in this, we pick the conjunctiva and tenons at once, and then with this help of the scissor, Westcott scissor, we are cutting the conjunctiva and tenons. And what I tell my residents is, holding this sclera is the most important step. Basically, what I tell my residents, because unless we stabilize the globe, your surgery will not be perfect. The globe is stabilized, you can proceed further. See, I just give an incision, frown incision, and then moving anteriorly in center. Side by side movements. The blade is visible clearly anteriorly. And once we go up to 2 mm into this cornea, then sideways movement towards the corners. Now to the other side. See, side by side movement, sweeping. So once the end is complete, now I move one end to the other end. So this is how I created a tunnel. Now entering into the anterior chamber. Again, stabilize the globe, and then side by side movement going up to the tip of the tunnel till where we have made the tunnel, and then down and straight in. So it's a triplane. And we cut the internal incision while going inside. So the wound is entered. And you can see at the end of the surgery, if your tunnel is perfect, the wound will close nicely.
Dr. Nitin, we just
Yeah.
have a few questions if you can answer them here. There is Dr. Silesi from Ethiopia, is how to decrease risk of post-op astigmatism. And similarly, there is Dr. Faruqi from Pakistan, who has said how to decrease the post-op cylinder. Even Dr. Khalid Abdul Rahman from Kenya and Dr. Ayubulan from Indonesia. All of them have the same question. I know you showed it, but if you can just make a quick
Yeah,
comment, sir.
in this, I'll just say that what I said previously is the length of the incision and the distance of the incision from the limbus. So the perfect incision length will be distance will be 1.5 to 2 mm from the limbus. Basically, we do is 1.5 mm from the limbus, just posterior to the blue limbal zone. We just give an incision. Now, how big the incision should be? Since we are doing in SICS, the incision length should be almost around 6 mm to avoid astigmatism. So if it's less than that, then there might be complications during nucleus delivery. And if it's more than that, that will cause more astigmatism. And if you go up beyond 1.5 mm from the limbus, then there are chances of premature entry and other more complications. And coming less than 1.5 mm, the wound will not close properly. There will be chances of buttonholing, and there will be chances of causing damage to the cornea. So that will cause more astigmatism. And there might be chances that you might have to apply sutures. So when you apply sutures, there will be more astigmatism. So the concept of this MSSICS is to avoid sutures and make a tunnel so that it's self-sealed. So to avoid astigmatism, what we need to keep in mind is two things. The length of the incision should be 6 mm, around 6 mm, and it should be 1.5 mm from the limbus. Thank you.
Thank you, sir. Even Dr. Sat.
We can't hear you, Dr. Gogate. You are muted.
No. Dr. Sumarti from Indonesia and Dr. Satyavan also had similar question. Please go ahead with your second video, sir.
Yeah. So now I'm showing you a video of buttonhole. This surgery was performed. Yeah, this surgery was performed by my resident. So I just recorded it after the complication was done, basically. So you'll see this in this video. Yeah, you see this. This is a buttonholing in the sclera. Since she made it quite superficial, now I am managing the incision. Since it was very much superficial, what I did is I made another plane of the incision. I just made another incision deeper to that, and it entered from the other corner. Say avoiding, I am deeper to the buttonhole.
So you've left the first plane as it is and you've created a deeper plane.
Yes. Yeah, I just created a deeper plane because the first plane was quite superficial. So there was enough space for me to create another plane. See, the new plane is created. Now in the next video, I'll just show you. See, after completion of the surgery, see, this is the buttonhole area. Yes, the wound is well opposed. The eye is firm. So now, since this was a superficial, the wound was superficial, I managed to do it by making a deeper plane. Just in case the surgeon was in the proper plane and they had created a buttonhole, what would we do is we just had to suture the scleral wound. And suppose the buttonholing is in the cornea even. If there is buttonholing of the cornea, then also we have to apply sutures. There is no any other options. We have to have apply sutures. Now, I'm
Thank you,
sorry,
sir.
but
Yeah,
yeah,
we
this
have
is
just
not my,
another 4 or 5 minutes. Yeah.
yeah, this is not my video. I'm sorry for that. I just downloaded it from YouTube. I could not manage my own. This is a premature entry management. In this, I'll just show how do we do it. You see, while making a tunnel, there was abrupt entry into the anterior chamber. Yeah, now it's the anterior chamber is entered. So after completion of the surgery, I'll just short of time. So what we do at the end is we apply sutures. So there's no any other option when there is a premature entry. We have to have apply sutures because initially the wound might be opposed when you close it, but later on with a minimal trauma or even during dressing of the wound next morning, the wound might leak and lead to endophthalmitis. So it's better to be on the safer side. We apply sutures. And if there is iris prolapse, then we do have to apply sutures. But sometimes there is no iris prolapse even after premature entry. So in that cases also we should apply sutures.
No, I think that's a very important tip you gave us, Dr. Tulsyan, that sutures are very important and they are very much needed for safety. So whenever there is even a smallest bit of doubt whether to suture or not to suture, it's always better to suture.
Yes, right.
And Dr. Tulsyan also didn't do the cautery, like one question was asked, that
Yeah.
if we don't do the cautery, there may be a small amount of oozing, but it does not interfere the surgery, and post-op astigmatism is always better if very less or no cautery is used.
Cautery is used. Yes. So now this is my second topic, that is Decimates membrane detachment.
So we will have to just drop in.
Yeah, I'll just do it fast. Because in this, basically it's classified divided into simple detachment, symmetrical detachment, and complete detachment. This is post-op. Now in intra-op, I'll just go into the intra-op. This is a management during a phaco. While during phaco, there was a decimates detachment, which we can see in the intraoperative OCT. There is a hanging of the decimates membrane. So how do you manage these cases is, one thing, while doing SICS, if there is a detachment, very minimal, small detachment, what we can do is, if the wound is nicely opposed, we can just do an air tamponade if the detachment folds on itself. Now, if there is a big detachment which is not unfolding on itself, then we have to apply sutures along with an intraoperative. We can keep intraoperative air tamponade, or we can use C3F8 gas for longer duration. But generally, what I do is I use air tamponade, and most of the time there is no post-operative edema and the DM is nicely settled. And the third and the last topic is anterior capsular runout. So when this happens because unlike most routine cataracts, the white intumescent cataract is fluid filled and has an increased intralenticular pressure. So when the capsular bag is punctured to start the capsular axis, posterior pressure is exerted anterior lens capsule, and that causes it to tear uncontrollably. So this is the Argentinian flag sign. So this is a video performed by my resident while doing capsulotomy. Can see when she gives a nick, there is extension of the capsulotomy. It's getting extended here. It's getting extended here also and on this side also. See, it's come till here. Now it's still here. Now it's almost complete. So I made her stop right there. And then what I did is I entered the wound through the tunnel. And then with the help of the banner scissors, I just gave incisions in this upper flap and the lower. From both the sides. And with the help of the rexis forceps, just completed the capsulotomy.
Thank you, Dr. Tulsyan,
Yeah,
sir, for the wonderful
yeah.
video. If you
Now,
can just come up in a minute, so then
yeah,
we'll have
yeah,
Dr. Haripriya.
just a minute. Now in this is what I did after the complication happened. So what can we do to prevent this? So how can we prevent is we increase the pressure of the anterior chamber with the viscoelastic. The pressure should be more than the intralenticular pressure. So when the pressure of the anterior chamber is more, when we give a nick, it does not extend. Now another procedure, what we can do is we give a nick in the center and drain the fluid from the intralenticular. So the pressure in the intralenticular is decreased and we can continue with the rexis. In this two way, we can prevent the run out. And the third is we can even do an envelope technique. We just open the tunnel and give an incision and give two nicks with the venous on other sides. And we can complete the surgery. So to summarize my surgery, I'll just, this is a video. We hold the connecting tab and tenons at once, give a nick.
So we will have this at the end if we have time, because we've already done 25
Yeah,
minutes. We
yeah,
have
this
two
is
more
done, sir.
speakers to go.
This is my summary, sir.
Yeah,
I'm
okay.
done. So we can see the lens is placed and the surgery is complete. The wound is formed.
Wow.
So this is from my side.
Thank you, Dr. Nitin. In fact, Nepal, if you see per capita, does more cataract surgeries than any other country in the world, because they do a lot of surgeries on Indian patients too. Over to you, Dr. Haripriya, ma'am.
Yeah, thank you so much, Dr. Gogate and Dr. Hunter Chervik. So I'll be talking on the nucleus management. I think we had an excellent lecture about making the right tunnel. So I think the making a right sized tunnel and a capsulorhexis is an important precursor for managing the nucleus. So the question is, what is my preferred technique for nucleus extraction? Please answer now, whether it's a fish hook technique, irrigating vectors, viscoexpression, Blumenthal, or do not routinely perform SICS. So we'll take a few more seconds before we close this question. So we request all the attendees to please respond, so we know how many of you are doing SICS and which is your most preferred technique. Thank you. That is a very interesting response, and seems like visco-expression and irrigating vectors. So I think equal distribution of both these techniques, followed by the fish hook. And 14% don't do SICS. And I think end of this symposium, hopefully we'll have more of you attempting to perform this technique with, of course, the appropriate guidance. And 5% do the Blumenthal. Thank you for the responses. So the nucleus management includes both the nucleus prolapse and extraction. Prolapse is to remove the nucleus from the capsular bag into the anterior chamber, and extraction is to remove it from the anterior chamber outside. And this prolapse, you need to have a good sized rhexis and a large enough pupil. And for the extraction, we'll have to have the right sized incision. Now, to be able to have the right size, it's important that the surgeon is also be able to estimate the size of the nucleus fairly appropriately, which again happens with time. And that's why initially when a surgeon starts doing SICS, it's better to go in for the straightforward immature cataracts, which have a more softer nucleus and are more malleable. When going on to the more difficult, harder nuclei, more smaller pupils, one will have to make further modifications in the technique to be able to prolapse the nucleus without any problem. So for the nucleus prolapse, the most commonly used techniques for an immature lens with a large pupil is the hydroprolapse. This especially would require a large capsulorhexis. This would be an important area for us to be able to have the nucleus prolapse out with the hydrodissection. So with the hydrocannula, one will have to take the cannula and introduce it right under the anticapsule rim. So you have a cortical cleaving hydrodissection. You can see the fluid wave and one pole coming out. And in this case, the same cannula, the hydrocannula is used. One can also use a Sinskey hook and then lift and rotate the nucleus to bring into the anterior chamber. So like I said, this large rhexis and doing a cortical cleaving hydrodissection will bring the endonucleus and the epinucleus out. And this makes your nucleus extraction and cortex aspiration also a lot more efficient. If you had a smaller rhexis, one will only have the endonucleus out and not the epinucleus, which then has to be removed with either the visco expression technique or the Simcoe cannula. The second option, in case the nucleus does not prolapse, or in a brown or a white lens, the other option is to have a mechanical prolapse of the nucleus. For this, again, I think all of these techniques is important to have an adequate capsulotomy, be it a capsulorhexis or a can opener. Now, when doing a mechanical prolapse, after or without hydro, if you're doing a can opener, we don't do a hydro there. It's good to have the nucleus prolapse. So I normally advocate this for beginners. Take your Sinskey, start from the center, go to the periphery, and then lift one pole. This way, there's no risk of hooking the anterior capsule rim. And then you will get a good firm hold on the nucleus equator, which will then enable you to prolapse your nucleus completely into the anterior chamber. And the vectors can then be introduced below the nucleus. And the irrigation from the vectors helps to remove the nucleus along with the mechanical forces. Now, talking about nucleus extraction, like I said, the most commonly done technique in our institution is using the irrigating vectors, which is what most of our surgeons use. So we use a vectors here with 3 different ports. The vectors is introduced once the nucleus is completely in the anterior chamber under the nucleus, and ensure that it is holding the nucleus well. At this point, when the superior pole of the nucleus is engaged in the tunnel, at this point, 3 actions are very critical to have a good nucleus extraction. One, you'll have to depress the posterior lip. This way, the tunnel opens and you don't have much of endothelial damage. Second, you of course have to hold on to the bridal suture or hold on to the globe. So the globe stability is important. And third, you also inject the fluid since your vectors is an irrigating vectors. And the hydrostatic forces also helps the nucleus extraction along with the mechanical forces. So doing all of this after the nucleus, the superior pole is engaged in the tunnel, helps to have a very comfortable nucleus extraction along with the right size between the tunnel and the nucleus. Now, this, like I said, you will have to check if the ports are patent. Introduce it gently. Ensure the rim is seen under the nucleus. Depress the lip, and then you can gently extract the nucleus. I normally
in your
use...
institute, you always take the superior rectus bridal suture?
We don't. No, I prefer to go temporarily for almost all cases because they have against the rule astigmatism, which is also a question.
You do temporal SICS regularly when you do it?
Regularly when I do, because most of them are elderly and they have a steeper horizontal meridian. So I normally go temporal. If they have a with the rule or a young patient, I go superior. Otherwise, almost always I go temporal. And I hold the conjunctiva. So that is what I hold instead of having the bridal suture. So a beginning surgeon, I think a bridal suture will be useful because you get a hold. But then one may also choose to migrate to just holding the globe with the forceps for both your tunnel construction and for the nucleus extraction as well. The other technique as an option would be the phaco sandwich. And here again, I don't do much of this personally, but this probably is a technique which some surgeons would use for a harder nucleus. If you want to remove it through a smaller incision where you sandwich the nucleus between the vectors and a Sinskey hook and then remove it. So this way you can remove the nucleus through a little smaller wound. Now this can work in brown lenses. Please remember that the vectors has to be held in the non-dominant hand, so which for most of us is the left hand. So that is inserted first. So you hold, so we may get confused. We think, because we always use the vectors on the right hand. So insert the vectors first, which is held in the non-dominant hand, and then the Sinskey hook goes above it. So to kind of sandwich the nucleus. Now, one has to remember that this can cause a little bit of crowding in the anterior chamber because you have a large nucleus and you have these two other instruments as well in the AC. So one has to be conscious of this. It also helps to have your assistant stabilize the globe, because otherwise the globe may move towards you when you're trying to remove the nucleus. Again, as I said, most of us do the irrigating vectors technique, but interesting to see that there's a varied response from the audience, and each one has I think quite a few are also doing the fish hook. So whatever works well in your hand is fine, as long as your outcomes are good, your cornea is clear, and you have less chance of complications, either intra-op and post-op. Now, in case you have a brown cataract, then one has to modify the technique. So how do you know it's brown? Of course, you have to see the patient pre-op, see on the slit lamp, and have a fair idea. Like I said, start with the softer lenses, but then once you go to brown lenses, consciously make a larger tunnel, obviously, to extract this large nucleus through this wound. A large pupil and rhexis are also mandatory. And again, you may have a little, the zonules may be slightly weaker. So have a more controlled hydrodissection and do not plan for hydroprolapse because you have weak zonules and it may not actually come out because you have a large bulky nucleus and it's about 8 to 9 millimeters and rhexis may be 6 millimeters and it's not as, malleable as a soft lens. So it may not come out. So plan for a mechanical prolapse when dealing with the brown cataracts. A large rhexis is mandatory here, and most of these patients are very elderly patients and they have thin capsules, and that enables us to make a large rhexis. But in case we have a small rhexis, do ensure that you can make at least 2 or 3 relaxing cuts if you don't do a double rhexis and then prolapse. So hook the equator, bring it out. Once you have a large rhexis, you find that this mechanical technique works well. Just go to the periphery, hold the equator of the nucleus, and then bring it out. And ensure you see the rim. Even in this black, almost brown cataract, you can see the rim. That is important for us to be able to see before you extract to prevent any inferior iris dialysis. Now, this is an alternate technique where you're using a bimanual technique. A bimanual technique, I think, is very useful. So please note that you're having on the dominant hand, we're using the Sinskey hook. Non-dominant hand, you can either use a Sinskey hook or use a cyclodialysis spatula. I use the spatula in the non-dominant hand. So once you have the first pole come out, so you take it from the center, go to the periphery, and then you lift, you rotate the nucleus, and the spatula goes below it. Now this acts like a support system for the nucleus. It acts like a fulcrum over which you can rotate the rest of the nucleus. Now at this point, I find the AC is shallowing. So I go back and inject visco, but this support prevents the nucleus to go back into the capsular bag. So one, it can act as a fulcrum. Second, I can also use it as a sandwich. So I can hold from below and above and help to bring out this large nucleus. So this bimanual technique works very well. I think it is, if you have a larger nucleus or, but please remember this is no compromise. Just because you have a large nucleus and you have a bimanual technique, you will still have to have a large enough rhexis. Otherwise, the nucleus will not prolapse out. And there may be a compromise to the capsulozonular apparatus. Now, this other case is just to show you, like for nucleus extraction. Like I said, I almost always would insist that the surgeons bring the nucleus into the anterior chamber completely and then extract them. Now, this could be one exception, which is in a hypermature Morgagnian lens. A capsulorhexis is being done here, but an envelope capsulotomy works just great. Just ensure that your capsulotomy size is large enough. You don't want to compromise an already weak capsular bag. It's thin capsule, weak zonules. Now this lens is just dislodged. So it's again small nucleus, but also a very hard one. And this may not be easy to prolapse into the AC. So once this is loosened up, though it's not in the AC fully, you can still use a vectis and then remove your nucleus because here it is loose. Otherwise, if you try to take your nucleus out using your vectors with a partially prolapsed nucleus, you have a high chance of zonular dialysis or even an iridodialysis. So please remember, always focus on bringing the nucleus out into the anterior chamber first, and then do a nucleus prolapse with your vectors. So now what happens when you have a slightly smaller pupil? Now aim for maximal dilation, use adrenaline, epinephrine, make sure you're using viscoelastic. I normally use the multiple sphincterotomy in SICS. I don't use iris hooks because with iris hooks, you have crowding, you have 4 hooks, and there's no place for the nucleus to come into the anterior chamber. So while hooks work great for phaco, I don't think it works well for SICS. For the small pupil cases, one can also consider stretch pupilloplasty. Now, when you make these sphincterotomies, you may not actually have a much larger pupil, but you will have a more stretchable, more flexible pupil. And this is very important to bring the nucleus out into the anterior chamber. Please remember, because your pupil may not be larger, in spite of the sphincterotomy, you will have to, again, make a larger capsulotomy, larger than the pupil. So you have to go below the iris and make a larger capsulotomy, either a rhexis or can opener, whatever you're comfortable with. And if you're using a can opener, again, a hydro procedure is not used. One can either consider a mechanical prolapse or bimanual prolapse in these small pupil. Obviously, a hydro prolapse will not work. So there's no point trying that again and again. Just do a good hydro dissection and then do a mechanical prolapse if you've done a capsulorhexis. If it is a can opener, you can go in straight for a prolapse directly. Now, this patient has pseudoexfoliation and a small pupil. It is a white lens, but it's hard. The patient is elderly, so I make a larger tunnel. I make 4 small nicks. So I make it so I think you can either choose to do 1 nick, but I like to make it 4 because it gives a uniform stretchability. And the pupil is, of course, it's still irregular, but it's still not too disfigured. So I normally do that. And as mentioned, make your capsulotomy larger than your pupil size. It's not enough if you match your rhexis to this pupil. So it has to go below the iris. A can opener works perfectly fine, but just be meticulous, ensure you have a good can opener. Sinski, take it all the way out to the periphery, hook 1 pole, and then rotate as you're lifting it, also rotate it with your Sinski. So you can see this pupil is small, but it's able to accommodate this large nucleus because you've done the sphincter. That is the power of the sphincterotomy. So the goal is, of course, a little more visibility, but the goal is that it gives you that stretchability, which then can accommodate your large nucleus. Sometimes if you find that midway you're prolapsing and it doesn't work, one can consider, to push your nucleus back and then do a sphincterotomy. Or if you're sure there's no capsule there, you can even do a slight ST with your nucleus partially in the AC and then continue trying to prolapse it out. Now, with the can opener, you will aim for a mechanical prolapse and a Sinski hook is used. And this is a case which has like a, again, a pseudoexfoliation, and there's a subluxation as well. So you can see here, there's loss of zonules. It's a hypermature lens. So a capsulorhexis is initiated, but it does not seem to work. There is a lot of fibrosis. So you don't have to have a rhexis in SICS. If you have, it's good because you can have capsular fixation. Otherwise, a can opener works just fine, especially in brown and white lenses. Just ensure you're having a completely, a large enough capsular opening. The cystitome itself is used to hook it from the periphery. So first you go to the anterior surface, move it to the other side, get 1 pole out, and then use the equator to rotate the nucleus out. Once this is done, then you use your vectors. Now, this is an irrigating vectors, but I don't use irrigation here when you're dealing with a hard cataract with weak zonule, with loss of zonules. Why? Because if the fluid can go and hit it can cause more vitreous prolapse. The bag is there, but as we know, there's no zonules in this 1 quadrant. So I have fixated this haptic alone with a Tenno proline sutures. I did an iris fixation of 1 of the haptics after keeping the IOL in the sulcus. So what is the most common difficulty I face with the nucleus prolapse? Please respond. Is it cheese firing? Is it that the prolapsed pole slips back into the bag, or the pupil constricts so unable to prolapse, so the nucleus is stuck to the pupil? Or I do not routinely perform SICS. So, I mean, I'm sure that all of us have had these issues. And again, there's a fairly good distribution, most commonly being the prolapsed pole slips back into the bag. I think this one thing can, making a larger rhexis, a sphincterotomy, and a bimanual prolapse will help this. And pupillary constriction, so unable to prolapse, again, this sphincterotomy, like I said, is very useful. So please, I mean, I know we normally don't like to go and mutilate, we don't want to cut the iris, but that probably is the most effective thing to do when stuck with a small pupil and a large cataract. Other complications could be the nucleus is stuck in the pupil, or there could be some cheese wiring as well. So with cheese wiring, this mostly happens because of, with very soft lenses. So make sure you have a large rhexis and do a good hydro procedure. That can make it much easier than trying to prolapse it out mechanically. And if the pole tends to, slip back, make sure that the force is always upwards. As you dial, try to keep having your force upwards, put visco between the prolapsed pole and the iris as soon as you remove your Sinski, or support the prolapsed pole with your second instrument from below so it doesn't go back. So just try this, and this actually works very well as well. So just to show you a situation where in case you hook the rhexis, the anterior capsule rim. Now this is a mock surgery in a wet lab scenario, and this is what happens, right? We tend to have a zonular dialysis. This can happen because your rhexis is too small or your pupil is too small. You don't know where your Sinski is being placed, and then you have a dialysis. To manage this, one will have to go to the opposite side. You have a zonular dialysis, lift the pole, support from below. Don't continue on the side of zonular dialysis, and then use your support with your spatula, and then bring the nucleus out with both the instruments. So this way you will be, especially this is probably a 3 to 4 clock hour zonular dialysis, and this technique can help you ensure that you still can have your bag there. Now, this is actually a patient with subluxation, but I'm just showing you this video as to how you can manage a case. In case this was a real surgery and you found this is a zonular dialysis during your prolapse, you will first, if this is a larger one than the previous mock surgery.
In another 2 minutes, we'll hand over to Dr. Alam.
Yes, I'll do that. Yeah. So you will have to get one pole out, and on the opposite side, get it out into the anterior chamber, and then support from below. Again, no hydrodissection here. Support the capsular bag and remove the cortex completely before the CTR is placed. Now, this can be one technique. So the CTR, if you place it straight away, you may miss the bag. So if you have a zonular dialysis, go through the side port, insert the ring, and then with the hook still in place, the CTR is guided, the trailing eyelet, especially with the second instrument, the Sinski is used. And then the IOL goes in the bag with the hook still in place. So cortex aspiration, you can use the Simcoe cannula. And please remember, the aspiration port is in the front, in the tip. Irrigation port is in the side. Ensure the aspiration port is occluded, so you build vacuum and then you remove it. One important tip which all of us do is go to the side port for 2 reasons: to remove the subincisional cortex and to prevent any positive pressure, which is also not uncommon with the large tunnel which we have with SICS. Finally, I'm just talking about IOL implantation. You place the lens in the bag. I am placing a single piece square edge PMMA lens. Ensure both the haptics go in the bag. Use viscoelastic, distend the bag well. And this actually, why do we do a single piece square edge? So we actually did a randomized control trial where we compared a round edge and a square edge. And we saw them up to 9 years post-op. And even with this, we saw a huge difference, a huge benefit when we use the square edge PMMA lens. So this, I think, is a great option which we give for our outreach patients. They don't have to come back to us later on for issues with PCO. So thank you again.
Thank you, Dr. Haripriya. A 9-year follow-up is awesome for, cataract surgery. It's unheard of. Thank you. Professor Alam, sir, if you can share your videos.
Hello, everyone. I'm Professor Sarar from Bangladesh, and it's my pleasure to be with you. My topic of discussion today is best practice tips and parts of a successful case. And in my presentation, many things has been already said, so I will skip some of the slides. My first topic is the architecture and measurement of a standard wound, architecture actually describes the number of the incision plane, either uniplanar, biplanar, or triplanar. The MSICS uses this triplanar incision, which is watertight and self-sealed. And we have to understand the wide length and depth of the incision. What does it mean? And some of the dimension which already has been discussed, I am not repeating it. And we have to have a conception of the different plane. The first one is vertical, second one is along the slope of the sclerocornea, third one is oblique into the cornea. In the vertical first plane, several incision can be given. The first one is the straight one, and the second one is the front incision, and the third one is bat wing or inverted front. The front incision, as has been already said, it is useful for delivering the hard nucleus, large nucleus, but it is difficult to master sometimes. So many ophthalmologists prefer to switch over to modified front, then they learn the front incision. And the second plane is the making of the tunnel and scleral pocket, and already it had been discussed, so I am skipping this slide. And the third plane is entry. Already said that a dimple should be seen before entry, and this is the enlargement of the incision. Blunt incision instruments are preferred so that no internal injury can happen due to sharp instrument. And gross assessment of the depth of the tunnel is needed by seeing the grades of the transparency of the superficial flap over the crescent knife blade. If it is opaque, the too deep, so there might be injury of the ciliary body or chances of premature entry. If transparent, here, if we can see very thin flap, chances of buttonhole. And the translucent one is you can see assess that it might be of normal depth. This is a very good video which already has been shown. This video is borrowed from Prathamesh, and he has first shown how the buttonhole occurred, and quickly he went into a much deeper plane, and that buttonhole is problem of buttonhole has been corrected. And next is how to extend when we have a jumbo lens. We can see how large the nucleus is. First, we have to assess the nuclear size and use a plenty of OVD because it is almost occupying the whole of the antechamber. Then extension of the wound by some blunt knife, either crescent knife or blunt keratome. Next topic is OVD and trap and glue. How OVD become friend in MSICS? By maintaining the volume and the shape of the AC and by protecting intraocular structures. Next, please. I'm sorry. When to use OVD, it can be used over the corneal surface for clarity, for construction of the main wound, during capsulorhexis at the beginning and after completing each quadrant, after hydro and before delivery of the nucleus outside the wound, before IL introduction, during giving suture and pushing the vitreous back when PC rent occurs. Next, please. Which OVD to use? This is a very beautiful picture. There are so many complicated things are here, and it varies. OVDs varies due to the difference in the rheological property, surgical behavior, side behavior. But basic thing is that the cohesive one, high molecular weight, adheres as a single mass, so that can be used for space maintenance. And the dispersive one, low molecular weight, disperses and so they course better than space maintenance. Next one. Here in an example of cohesive and dispersive, the first drop is cohesive one. It does not spread rapidly. It tries to maintain in the same place. And with single wash, we can wash it easily. But the second drop is dispersive one. It disperses more rapid than the first one, and it is difficult to wash. It needed several times so that it is sticking to the surface. Next one, please. But when OVD is not our friend, when we forget to remove completely. We're thinking only of the OVD in the anterior chamber, but in the posterior chamber, above the IOL and below the IOL, if we don't remove, we have several complications like elevated IOP and uveal reaction. Next, please. In the capsular stain, in the first case, the immature one, we can see very clearly red reflex. It can be managed without stain, but in the second case, the Bruno-Sen cataract, it is almost impossible without a stain for the beginners. Next, please. And how to give OVD? We can inject directly and wash it with the BSS after a few seconds. Then it is workable to have a good capsular staining. Capsular staining and capsular excess can be done effectively. And sometimes there is another method of injecting under air. Next. The air is injected into AC, but it needs several injections because it does not want to retain. So under that, oh, it has come here. Okay, the next slide is a complication of giving the previous slide, please. This is a capsular staining going deep into the vitreous, though intact pigment is there. OVT was stain was given and retained there for a prolonged period. The case was a high myopic case and hypermature case. So those stain went through the dehiscence in the capsule. So it is evident that it is in the vitreous, but it will absorb after a few days, but it's a complication. Next one, please. And risk of staining the corneal stoma, if you don't understand where we are injecting. Next, please. The next issue is the issue of the knives. And when we use the reused knife problem. Now, second poll question is what you see in this picture. Injury to the lens capsule by the tip of the keratom, injury to the cornea by the tip of the keratom, injury to the iris by the side of the keratom, or injury to the scleral tissue by the side of the keratom. So you think and give answer. Answer is not coming. Oh, so injury to the lens capsule got the maximum 64%, and rest is injury to the cornea 22%. So the first one, next slide, please. First one is the correct answer. Next slide, please. There are several knives in the market, but whatever knife is used, sharpness is essential. For this reason, disposable knives are widely used. Next one, please. We can see the BP knife. It is used in the developing countries, which is less costly for making the first incision. Next one, please. I'm skipping this because it has been already shown. But previous knife is not guarded. Nowadays, guarded knife blades are available in the market. These are disposable, less costly than the diamond knife. Next one. This is crescent knife. Skip is already described. With the crescent knife, we can make the first incision, make the tunnel. We can also enlarge the incision after entry. Next one, please. And 15-degree side port entry blade for paracentesis. Next one, please. This has been already discussed, many of the topics, so I'm skipping. This is a sharp keratom, and during entry, care must be taken not to injure the structures. And this is blunt keratom for extending the wound. Bluntness, why? Because it can injure the internal structure if it is sharp by the beginners. Next one. How to avoid the complication when reused knives are used. Next. The creation of a triplanar incision requires sharp knives, but here we can see how blunt the knives are. In the first slide, there is comparison between a new one and old one, and the second one also. And the blunt knives result in rugged wound and premature entry. And in the lower part, the keratome tip is so blunt that it will cause so much complication. We'll show in a video, next one. We have recreated, next one please. We have recreated a scenario of using the blunt knife in the wet lab. This is a blunt crescent knife, and we can see how much pressure has to be given for creation of this tunnel. But at the end, wound will be rugged and the premature entry can occur anytime. And also, when we use with the blunt-tipped keratome, you can see how the desmoid membrane is tenting with the blunt knife. And there is great chances of desmoid membrane detachment. And this desmoid membrane detachment, if it is small, is undetected by the beginners. They can see it at the end. So in the next video, we can see, next video, here this undetected desmoid membrane detachments in the superior part is seen at the end of the surgery. Next one, please. Reused blunt side port knife, it is displacing the whole eyeball. So how dangerous it is. Next one. Effect of using this reused blade, you can see the margin of the wound is so ragged. And at the end, due to this, the wound leaking occurs. It is not sealing. Stitches has to be given. Next one, please. Now about capsular axis. Next one, please. Some of the few essential good visualization is critical for performing each step of the capsular axis. Excellent focus on the capsule is needed. Some need high magnification and finding of the red reflex. Exception is white mature cataract. Can you play the video? Red finding, if image in an immature one, if we can find a red reflex by adjusting the head of the patient, it is of great benefit of doing the capsular axis. You can see red reflex is found. Previously, it was not. And other things, essentials are liberal use of OVD and use of capsular stent if needed. Next one, please. What technique is ideal is asked by many persons. Actually, each surgeon try to choose a preferred technique, but more than one technique should be mastered because of the availability of instruments at different times and various patient characteristics. Next one. Need to use the capsular stent. In this case, immature one, red reflex, it is may not be needed, but here it is an absolute necessity. Without it, we cannot proceed. Next one, please. Next one, please. Routine capsules requires a balance between the force applied on the anterior capsule by the surgeon and against the counter traction force from the zonule and the force of the lens material. In this aspect, OVD comes as a great friend by deepening the anterior chamber and counteracting the counter traction force. Next one, please. We need to understand the vector forces sharing and reaping vector described by Sibel, which is the key to directing the path of the tear. The shearing force, as depicted in the figure, is the force applied in the direction of the tear, which requires less amount of force. And turn the video, please. Video, please. The capsular flap is folded like a folded napkin. Next slide, please. In a nutshell, I'm telling. Next one is reaping force. Reaping vector is applied more centrally to redirect the direction of the run-out capsular axis. Here in the video, we can see due to high interventricular pressure, capsular tear turns to extend, then surgeon draw it more centrally by the reaping force. If we don't understand these two forces and don't apply, we cannot have a good capsular axis. Next one, please. What are the preferable routes for CCC? It can be done through any port, but through the main wound, it might require application introduction of OVD several times. But if we can manage it through the side port, it is of great help. No additional viscoelastic is needed to administer into the anterior chamber. And it is convenient in many conditions like high positive pressure, hypermetropia. Those are great rescue. Next, please. Double rexis in case of already discussed in the Morgagnian cataract, first 3 to 4 millimeter diameter rexis is done, and then all the milky cortex are taken out by aspiration. The capsule is cut with the scissor, and it is then proceeded with the capsular rexis forceps. But frequent application of introduction of the OVD is needed at that time also, because lenticular pressure is also not below the average. So there is chance to extend. Next one, please. Few more tips. Rexis margin should be grasped close to the leading edge. This is great for more control. And frequent re-grasping of the flap every 3 to 4 is a great help. Next one, please. The last topic is the tips and technique of prolapsing a pesky nucleus, already described. Issue of the large nucleus. The large nucleus is a great headache for every surgeon, from the doing rexis, taking it into the anterior chamber and taking it it has this is a very beautiful depiction in the Aravind eye manual. It is shown how it is taken out. The wound construction, the size should of the wound should not be less than 6.5. The size should be proportional to the size of the nucleus, and fawn incision is good in this type of cases. And protection of endothelium by using plenty of OVD and nucleus delivery by sandwich technique. And multiple attempts might be needed. Next one, please. Nucleus delivery by sandwich technique has been already described. I'm showing my cases. Here, what danger is that you might catch the iris or anterior capsule. So don't grasp the two instruments so firmly till you are in the middle of the cornea. When you reach the middle of the cornea, they only you press the both instrument forcefully, so that during this moment, if the capsule or the iris is caught, it will be pushed back. Nucleus delivery by multiple attempts. Nucleus delivery by Henning's fish hook technique. It is from Dr. Henning of Nepal. A fish hook is prepared from 30 gauge needle, and after giving plenty of viscoelastic inside, the fish hook is introduced. I don't know what happened. Fish hook is introduced into the behind the nucleus above the capsule. Then it is turned. The needle is turned up and slightly pulled back, so that needle tip is engaged into the central portion of the nucleus. Then it is pulled out, and it is said that the learning curve in this technique is less, but actually we are not doing this fish hook technique. Next one, please. There are several other techniques which Dr.
Can
Aravind
summarize
has
in the next 2 minutes, sir.
But these techniques are not used because of various complications.
Thank you. It's a quick question to each one of you. All three of you are also fantastic phaco surgeons. I mean, I've heard Dr. Haripriya teach phaco so many times in the AIOS, in the American Academy. Dr. Sarwar, you teach at your institute, and Dr. Nitin, you are also a vitreoretina surgeon. So where in each one of you, since this is on manual SICS, we'll start with Dr. Nitin. So where would you have SICS as your technique of choice, even though you would have the best phaco machine next to you? I know you can do both of them equally well.
I didn't get you. Like, in which cases, like, will I be doing SICS or?
You would, I mean, you would feel that for the sake of the patient, SICS
Okay.
would be better or it would be more comfortable to you as a surgeon if you did SICS rather than doing phaco?
Yeah,
I know all of you do phaco
yeah.
in all kinds of cataracts.
Yes. The best thing in which I would prefer SICS over phaco is, one is hypermature cataracts, and the other is brown and black cataracts, brown-black cataracts, because in that cases, if we even go for phaco, and we are doing phaco even in brown cataracts, but what happens the next day is there is a lot of edema and the patient has very less vision, so he's not satisfied. So it's better to perform SICS so that he is having clear cornea the next day and has a good vision. And similarly, in cases like intumescent cataracts with shallow AC, in those cases, we can go for SICS, but still phaco can be done, but with some precautions.
Sure. Dr. Haripriya, ma'am.
I agree with Dr. Nitin. Yeah, so I think hypermature lenses, SICS is definitely a safer procedure. And also these very advanced cataract with weak zonules. So with phaco, you'll be putting more pressure on the zonal apparatus sometime. But if you can manage to make a large enough rhexis or a can opener comfortable, I think SICS is a better technique than doing phaco in those very advanced cases with little shaky lens. I think SICS works better there.
I totally agree with my previous two speakers. When I assess the nucleus, that if I do phaco, it will exceed the 3 minutes. Definitely, I'll go for SICS for sake of endothelium. I'm a cornea surgeon, and also zonular problem definitely. And in some of my cases of endothelial dystrophy, for taking care of the endothelium for extrapication, because I'm more confident to protect the endothelium with the sandwich technique. So I refer in those cases also.
Yeah, I think all of you put it very succinctly. I mean, to which I will add just two more indications. One is in very, very old patients who are 95, 100, whose endothelial counts obviously will not be great. And we get some of them in our camps, or who are not that affording, and again, where SICS can be done. And another indication, which in India, Dr. Boramani has been doing, is that because SICS gives a larger astigmatism than phaco, about 1 diopter, instead of using toric lenses, he uses SICS if the preoperative astigmatism is 1 or 2 diopters. So in many places in this world, toric lenses are not easily available, or even in our countries, toric lenses are not affordable by everybody because they are much, much more expensive, and we would have to have phaco and a lot of other things that go with them. So there also SICS can be a very good option. And well, I think that kind of sums it, but we still have another 5 minutes with us. So thanks to all of you for doing it in time. One other thing which people are very, very scared of is, with Dr. Nitin, that's not the case. He's a VR surgeon, but we are scared of PC rent. So that's another very common question that has been asked from various parts of the world. So if we have a PC rent during SICS, what would you do, Dr. Nitin, sir?
In that cases, I'll say first, how much is the rent? It's in the center, or it's occupying more than like 1/3, half of the area, or how much is the area rent? So if it's only the central rent, what it is, a very good anterior vitrectomy, and then we can even place the lens in the bag itself. If it's more than half of the area, then what we do is we do an anterior vitrectomy, a very nice anterior vitrectomy, so that the no vitreous is in the AC, and we place the lens in the sulcus. So it all depends. You need a support of the anterior vitrectomy, basically, because open sky vitrectomy, sometimes it does help, but it's not perfect. So if anterior vitrectomy is there, we can have a perfect surgery in spite of having a rent.
Thank you. Dr. Haripriya, ma'am.
Yeah, I think the good news is that SICS, the chance of a nucleus drop is lesser than with phaco, because in SICS, your forces are more upward, whereas phaco, with the fluid, your pressure is down. So in fact, during phaco, if we have a rent or you suspect a rent, I think most of us SICS surgeons, we feel lucky we can convert with SICS. So we make a different, like we're doing temporal phaco. I abandon that incision, temporal 2.2 incision, go superior, make a nice clear corneal incision comfortably, prolapse it, and then you can still do a vitrectomy and place an IOL in the sulcus. Continue with phaco in those cases, has a high chance of nucleus drop. SICS, two complications are common, both rent and zonal dialysis. Zonal dialysis obviously is more common in SICS than it is in phaco. I think whichever complication it is, especially when someone who's a beginning surgeon, anytime you feel something is not right, that question arises in your mind itself is an indication that things are probably going downhill. So please stop and reassess. If you find you're able to see the equator of the nucleus in the visual axis, then it means you probably have a rent or dialysis. That is, otherwise, normally you can't see the equator of the lens if it is not prolapsed yet. So all of those signs. So when you have those indications, better to do a bimanual prolapse. I mean, you still can have a nucleus drop, but the chances are far lesser.
Dr. Sarwar, sir?
Actually, I told all the time my trainees that first try to detect whatever complication, detect early so that you can manage in a proper way. If it's detected lately, we cannot do so many things. And what are the steps where trainees or beginners actually do more PCDN? Most importantly is cortical matter aspiration from the 12 lobe, sub-incisional cortex. So that measure has to be taken not to take that step into the dangerous level. And PCDN, as Madam has said, that is for SICS is more easy to manage than phaco, because phaco, all the events are so dramatic. You cannot, if you don't put attention, it goes on rapidly to more severe complications. And even when PCDN occurs, as Dr. Nitin has said, that where it occurs and what is the size depending upon that, but vitrectomy is a must, and so all the SICS or cataract trainee must learn how to do the vitrectomy. So proper vitrectomy, and then the questions of putting a IOL in the sulcus is not a problem at all, because we have not committed to the patient that will give the foldable IOL. So these are the things we actually tell students.
Thank you, sir. So would you also choose certain kind of cataracts to do SICS initially?
To me, sir?
Yes, sir, Dr. Sarwar, sir.
Certain kind of cataract means definitely hypermature Morganian milky cataracts. We prefer brown cataract. We prefer to do SICS. And another indication is that patient cannot afford to do phaco. The rural patients, many patients are not able to. So we don't hesitate to do SICS. In a good SICS, the visual acuity is almost similar to phaco if we take care of the astigmatism.
Yes, Dr. Haripriya has a large paper in it. I think one of the largest series, 45,000 plus patients with SICS and phaco compared.
Yeah, I think complication while learning phaco is definitely more. SICS is probably safe. That's why I think in India, all of us insist that before our surgeons do phaco, SICS is a must, because they learn tunnel, the capsulorhexis and hydro procedure. So I think it's a very good skill. Even with phaco, if you have a problem for doing the horizontal chop, or if you want to convert, if you have a problem, if you have your SICS skills in place, it is very useful. And I think the aspect which keeps coming up for all of us is the astigmatism. So managing it, so one, to look at the pre-op astigmatism, how much is it? Most of them have against the rule. So can we go temporal? So not initially. So I think initially you would rather go superior, it's safer. Temporally, you find the limbus is thinner, so higher chance of premature entry. Second, you have a more cylindrical cornea, so you may tend to make the wound smaller, and your corneal valve may not be big enough. And because of this, you may have more iris dialysis. So someone who's done about 300, 400 superior SICS can comfortably migrate to temporal SICS. Just consciously make the wound larger, and your corneal valve has to go well into the cornea, at least about 1.5, if not 2 millimeters. That will prevent your iris dialysis, iris bleed. I'm sorry, your wound bleeding from the wound, and you'll have a good outcome. So that is something which we can also consider.
And ma'am, would you insist that all the trainees or all SICS surgeons also try to do a CCC, a complete curvilinear capsular access?
We actually do in our training program, we do start them off with a capsulorhexis, but we also, if they have a problem, of course, we can move to a can opener, because that seems easier for us than converting them from a capsule can opener to a capsular X. The other important reason is, like I said, the square edge PMMA. And we see this huge difference. The other arm I didn't show is that the square edge PMMA was compared to the Acrosoft single piece. And this did better than that as well in terms of PCO rates for 9 years. That is the power of the square edge. It's a single piece design, and it only works well if you have it in the capsular bag. So if someone can do a Rexis, so not a trainee surgeon, they'll have an issue. Can opener is fine, but again, brown ones, it's okay. But are they 70% of the patients, if they can get this, I think that will be good for most of our patients.
Great. Thank you, ma'am. One last question to you, Dr. Tulsyan, sir. Is there an indication where you would say we would not recommend manual SICS in cataract surgery?
Yeah, I think maybe if the patient wants some...
Yeah, it's a tough question.
If they
I
want
think
a specific, like a multifocal or something, I think their phaco is better because you have a more predictable outcome. So if you want a good refractive outcome, because SICS, the one thing is we cannot actually predict the actual astigmatism our wound will induce. So if you want the newer IOLs, I think their phaco is better rather than SICS.
And
Dr.
also
Tulsyan.
maybe patient with bleeding disorder, where great chances of bleeding. So
True.
we can think of that.
Dr. Nitin, if you would want to add something, sir?
Like, yeah, if there is a patient has already gone for like previous surgeries, like even glaucoma surgery or bleb surgery, or there is some implants, valves are there, then we definitely prefer phaco over than SICS.
Great. Thank you. Thank you to all three of you, Professor Sarwar, Professor Haripriya, Professor Tulsyan. You gave your time for this. And of course, thank you to CyberSight, Orbis, Dr. Hunter Chevik, Lawrence Sika, and Andy Chen for making all of this possible. And last but not the least, the most important, all our participants from across the globe who gave their time. And at some places, it's really very odd hours, but you still came and attended this webinar. Thanks a lot. Thank you once more. Thank you.